So welcome everyone who's in this meeting, and lovely to see you all. This meeting should only take 1.5 minutes and hours. I know you were looking for hopeful there for a second. We have prepared our presentations per video, so we should be keeping to time. And between the videos, which all really only take between 3 to 4 minutes max, we then will open the plenary for questions. You will find that polls will open up during the presentations, and you can answer those questions. That would be helpful. And the chat obviously is open to make any comments. At the moment, you're all muted, but obviously we'll make sure that you can give opinions. You can raise your hands as like in any meeting, and we will answer your questions. I will quickly introduce our team here behind us, even though I think you should know all of us. So my name is Dr. Marcus Maiden-Tilsen. I am the CEO of KIC and one of the directors, and I'm a GP in Ramsgate. So I'm going now to my right.
Oh, Sandra Muirhead. I'm the ACP lead. I'm sure most of you know me, and also I'm Director of Quality for Thanet.
I'm Stephanie Giorgio, GP and the clinical lead for the QEQM UTC.
I'm Graham Haggerty, Director of Operations and also Business Manager at Minster Surgery.
Lovely. Okay, so I think we will just start with our first presentation now. So that's a pre-prepared little video. So again, any comments on the chat are welcome. So I'll talk to you in a minute.
Activities over the last year. First of all, I would like to give you an overview of our activities over the last year. And we've been busy, so have we all, haven't we just? So I would like to thank you, all of you, for the hard work you've been doing to keep services going and our patients as safe as possible in those very, very difficult circumstances. So we as a company, we have been also busy, and we supported the practices on a practice level. First of all, with the transition from the PCHs to the PCN to some degree, but also helping you out with the infection control and coping with COVID. And we established this hot site forum, which now becomes a wider forum and meeting between us all to discuss all sorts of matters within Thanet. And we were able, luckily, to support a couple of surgeries when they had to close and maintain the services for a few days. At a wider scale over Thanet, we have also been helping, and we facilitated the opening of the hot site, which obviously is a major achievement for all the practices involved. Being able to, within 10 days, open a center has been a really wonderful thing to do. And then we have the pharmacists in practice. That was just tailing off because obviously this has been now fully handed over to the PCNs. We've been supporting the practices with the extended access, and I would like to point out that we're offering 1,500 appointments per month for the extended access. So that's quite a lot of work we're doing. Furthermore, we established a home visiting service. So this service in the last 6 months has seen near enough 1,300 patients and saved overall around about 16 weeks of GP appointments. But we've not only been working at Thanet level, we also had to work at East Kent level. So there are two major arms to this. One is the CART, which is obviously in conjunction with KCHFT, and we've been fortunate in procuring the GP element of the contract of CART, and we will support our GP, our primary care element of this. And CART itself is a national trailblazer. It's been recognized by NHS England, and we assume that it has seen around about 5,000 patients so far and avoided a little bit more than 1,400 admissions, a great achievement of CART. And furthermore, then with EART, the GP and A&E, this has now been superseded by the Urgent Treatment Centre, and we've been successful in getting that contract, and I will go more detail a bit later, and working close together with ECHAFT and furthermore providers in the area. So we have now a fully established model working in the front of the A&E department. And we've seen so far in the past about 17% of the A&E attendances. This probably will change under the UTC model a little bit, but this has been another success. So we've been doing really well. We've been very, very busy indeed. And I forgot to mention actually that we also got CQC rating good in November last year. So another cause to celebrate. Well, you will find more details about all these different projects in a minute. So I thought that should be a good starter for you, and I'll see you in a minute.
Right, okay. So welcome back everyone, and I see a few more faces have appeared, which is wonderful. It's great to see you. I just want to mention that all the documents supporting this AGM are on the web link I just put on the chat as well. So you don't need to fish for emails if you feel tempted to do so. All the documents are on there. You can read them there. Also, there's a feedback form which we would love you to obviously use and feedback to us. So are there any particular questions so far from anyone? So if you raise your hand or wave for people obviously who have activated the video, but the others who haven't, if you just raise your virtual hand, as it were. Okay, Jenny, you have a comment or question. So
yeah, I just wanted to ask Marcus, have you thought about publishing some of your achievements so that the wider, the wider part of the UK can see what you've been doing to celebrate it a little bit?
Sorry, I will put you on a different audio because I had difficulties hearing you. I assume everyone else could hear you. Could you ask the question again?
I was just asking, Marcus, whether you thought about publishing some of your achievements so that the rest of England can actually understand what you're up to, and maybe you can share best practice around the country.
Well, one of the things we definitely will do after the AGM, our website will be overhauled, and all those sort of things will be put on our website. But we would, of course, will be happy to share. We obviously work with the NAPC, and we will make them aware of what happened, which will help to put it on a nationwide sort of platform. But your support in that is also very much needed, really, to bring it out and publicize it in a way, and that's true for everyone. So we will have all the resources ready for you, and we'll come to that a bit later as well in the meeting. Thank you.
Thank you.
Right, I think we will now come to the operational report. So again, these obviously will be our pre-prepared videos, which hopefully should make it very quick and slick for you. Again, the chat is still open, and there will be some polls appearing every now and then, so don't hesitate to answer those. So we start with the home visiting service.
Hello, I'm here to talk to you about our home visiting service, which commenced on the 13th of January. It was commissioned by the CCG as a short-term pilot to address identified need within the primary care population of Thanet. In particular, its aim was to improve accessibility to healthcare for frail elderly and housebound patients, and to avoid unnecessary hospital admissions, and also to reduce pressure on primary care and hopefully free up some GP hours. Initially, we were required to see only patients in care homes, but this extended quite quickly to also include all housebound patients. We carefully selected our team to reflect the needs of the likely patient population, with GPs and ACPs who have a good working knowledge of frailty, palliative care, acute and secondary care. Our team model includes one GP, working each day, and a number of other paramedic practitioners and nurse practitioners working alongside that GP each day. We have found that over 40% of the patients referred have needed input from the GP in our team, and this reflects the importance of having a GP as the clinical lead each day. To assess our outcomes so far, we've undertook an audit of the first 6 months, and I've put some of our findings on the slide here. We saw 1,278 patients in the first 6 months, and of those, 96.6% were found to be acceptable. 74% of these patients were treated at home, and only 5% admitted to hospital. An important finding from the study was that we had managed to free up 639 hours or 16 weeks of GP time within Thanet in those first 6 months. These findings reflect that we continue to work hard throughout the first 6 months of COVID, despite a number of our team falling ill. And I'm pleased to say that all team members recovered and returned to continue the good work. We have ensured that from the moment the pandemic commenced, our home visiting service had access to full high-quality PPE at all times. An independent review was undertaken on behalf of the CCG, which particularly highlighted the strengths of the team, who were reported to frequently go the extra mile to secure the healthcare needs and requirements for the patients that they saw. Also highlighted was the good working relationship the team has with other service providers, including CART, the hospice, community nursing team, and the surgeries in Thanet. I think most importantly of all is the fact that the patients themselves have reported how professional the service was, how timely, and how it improved their access to healthcare. Thank you, and we welcome any of your questions.
Lovely. Okay, thank you, Sandra, for that. That was very good. So, can I open for any questions, any comments so far? Again, waving or hand raising electronically are very welcome. Okay. That's nice and quick then. We will carry on with the next presentation. This one is about the extended access. Ash put his hand up. We let him say something.
No, it was just wanted to say thank you guys, because as a lot of people who work in North Down know, we are clinicians down in our practice because of the COVID. And when the first wave hit, it was actually, you guys were godsend at that time. The way you responded and supported us during those challenging times, and not only just us, some of the practices which had gone down locally at that time, 2 other practices had to shut the door, were actually supported by the KIC during those challenging times. And in fact, one of the practices which has gone down in Dover is sending all its patients down to the UTC, which has flooded the UTC and has caused a lot of problem in the system. So it was very good of you guys at that time, because you used the home visiting service to support those practices who were in a very challenging situation. So just wanted to say thank you from our side.
Thank you, Ash, for that. Lovely. Any further questions or comments so far? Okay, we carry on with our extended access.
Good evening, everybody. I'd just like to give you a brief update on the extended access project. As we know, extended access started on the 1st of October 2018, and it was the government's desire to provide GP or primary care appointments between 8 and 8, 7 days a week. Thanet Health CIC was awarded the contract from the CCG, and we had a meeting with all the practices and practice managers and decided to do it with a sort of blended model where Thanet practices would be providing it from Monday to Friday, and the CIC would provide weekend and bank holiday cover based at QEQM. is initially for 30 minutes per 1,000 weighted patient population, but this increased to 37.5 minutes from October 2019. And we know there's a desire from NHS England to increase this to 45 minutes. But that should happen sometime within the new financial year. I'd just like to give you a bit of an update on the present situation. As you can see, our requirement is nearly being met by the practices on weekdays, and we are very close to getting it on the weekends and bank holidays. Unfortunately, COVID has had an impact on the delivery of this service, where the face-to-face appointments have dropped, and there is now a desire from the commissioners to increase this in the next few months. What I'd like to do is try and reinstate the meetings that we have with the practice managers so that we can talk about this collectively on how we want to take this forward within the PCNs to try and get these numbers back up. Contractually, we need to try and hit a 75% usage. And before COVID, we were at 72, so we were nearly there. And we know by introducing direct access booking from NHS 111 on a Sunday, that should help us hit that 75% target. So just want to give you a bit of an update as to what we do from a CIC point of view with regards to the commissioner's requirements on us. We collect the activity on a monthly basis, and we send it to the CCG. We do quarterly reports giving them updates, and again, this is one of the things that we'd like to discuss with the practice managers about getting some more of that data from the patients and how they view the service. We support practices by obviously paying the invoices that come in on a monthly basis. We will liaise with the practices to deal with any challenges they may have. With certain practices, they've obviously dropped out of the scheme, and those hours need to be picked up by other surgeries within their PCN. There's been a couple of practices that haven't been part of this from the beginning, and therefore other surgeries have taken on that allocation. And then just to touch on the future, from April the 1st, 2021, this will be no longer a CCG commissioned service. It will actually be directly commissioned to the PCNs. So it would be good, again, once we reinstate the meetings, if the PCNs and the practice managers and the KIC could actually agree a delivery model for going forward, where hopefully we can help deliver this project for you. Thank you very much. And if you have any questions, I'll take them now.
Thank you, Graham. That's very helpful. Yes, so I open the plenary to questions. We had one question from Jenny on the chat, which I sort of furiously tried to type, but my keyboard wasn't quite reacting in the way I thought it would. So Jenny was asking, would you consider using HCAs and clinical pharmacists for follow-up visits? Now, that's a very good question. Of course, as the provider we are, we want to consider any healthcare professional if they're useful to any of our services and how we use them best. And we are proud to be able to be an integrated healthcare provider using all the professional groups. Currently, the home visiting service is not commissioned to do follow-up services, and the CR service obviously is taking patients for a given time anyway already. So it would would have to be commissioned as part or an extension of any of these services. So that's, we of course always happy to consider other ideas and projects, but we need to make sure that they are commissioned and or paid for one way or the other. So yes, that's what I would answer to that one. Does it answer your question, Jenny?
Now, I was just thinking about the readmission rate, and quite a lot of patients are discharged from hospital quite quickly and thrown back into the community, and they're not really well enough, and just somebody like a healthcare assistant going around making sure they've got their medication, that they've got shopping in, for example, because sometimes you hear of stories of people being discharged at 4 in the morning. And it was just when I worked in Invicta, in the home visiting team, they had healthcare assistants who did that part of work, and they stopped the readmissions of patients who were discharged. And I was just thinking, that would be quite a good thing to have.
I entirely agree, but again, that would have to be
funding again.
Funded and commissioned, and that would be sort of a halfway house between CR and obviously home visiting service. And we we can obviously put the slider in there. A lot of that work should be done also by ECHAF, because part of their discharge services is to make sure that the patients are, looked after well. We know that phase on a regular basis, and there is a gap. So we're happy to explore that with the commissioners, and I will take that forward to the commissioners, that particular question. Right, any more questions in regards to the extended access? Any comments? That was an applause. Okay. No further comments. This is going really quick, so it's brilliant. So we're going to be done in an hour if it goes like this. We now have the pleasure to watch Steph with her presentation about the eArt and the conversion of eArt into UTC.
I'm going to talk to you now about the eArt service that we set up at QEQM to support the A&E department and our local GP practices, and then a little bit about the urgent treatment centre that we have now morphed into as of October 2020. The eArt service was very much set up to support the primary care system within East Kent and how that fits in with the urgent care that is needed at QEQM for our patients when they become more unwell. It was initially a very local project set up by the Thanet CIC and began in October 2017. Initially a few hours, and then we went on to 12 hours a day, 7 days a week, because it became very clear to the trust that we were providing a valuable service. As of October 2020, we have now become the Urgent Treatment Centre as per the NHSE spec, and we are part of 4 urgent treatment centres run by the Alliance. Now, Marcus is going to tell you more about the Alliance and the setup of that later within the presentations. We're now a 24-hour-a-day, 7-day-a-week service and are providing support to the A&E department, which has been particularly important during the last difficult times. One of the things that has been interesting is to see how many patients we are taking from those who walk into A&E. And we know that there's about 210 patients seen daily within QEQM ED, and we're seeing on average at the moment about 13.6% of their patients, but it has been much higher, particularly was much higher last year in December, which is not surprising given the viral illnesses that come along in the winter months. We were much quieter during the original lockdown because the system was much quieter, but we're now coming back up to levels of activity that we would expect for this time of year. I think the key to the success of Thanet CIC and the success of eArt was the people. We set up a very close network of GPs. We have about 17 GPs and 11 ACPs who work with us, and that has been a very good team, and we are very much a team approach. We support each other. There's a GP and an ACP working at all times, and they work together closely to make sure that they're supported. We also try to have an education system within our service so that there's professional development for people. We have a good coverage of the rota. The rota team work incredibly hard to make that happen. The system that we have is based on EMIS so that we can liaise with our local practices and make sure that the communication flow between the practices and eArt is as good as it needs to be, because that's the absolute key to maintaining patient safety. We are bringing those elements into the UTC to make sure that going forwards, that communication is as good as it ever has been, and we will continue to make sure that we work really hard that you and your patients know exactly what's happened if they come to see us at the UTC. We've been incredibly flexible. We've had to be. We're a very small team. We've worked within another department, and we've had to adapt if they've needed us to move. Since the beginning of the pandemic, we've been working in a completely separate bit of the hospital to the ED, and we've had to show amazing flexibility, and I'm really proud of our team because we have shown that we can work and adapt to quite difficult working conditions. I hope that's given you a little bit of an idea of what we do and how we fit into the system. If you've got any questions, I'm very happy to answer them.
Thank you, Steph. That was brilliant. If there are any more questions, of course, I take them now. Otherwise, we go right into the information about the UTC. So, any questions, any comments?
Could I ask, Mark Speller here, regarding the footfall, you want to reduce the footfall of just people turning up to the UTC, and you want to use 111 to book slots in general, reduce that footfall and make it more organised and less chaos up at the department. Now, 111, the outcome is a bit variable, and you might not get what you were hoping. So if the GP thinks, well, you know, the GP in the practice thinks this patient needs to be seen urgently up at the hospital, but you don't want to just say, turn up. You want to get it done in the right way. But 111 then says, speak to a GP within 1 hour in your own practice. You know, the patient goes around the system. Is there any hope that that could be smoother going forwards? Has that been talked about at all?
Okay, so I think Seth would love to answer the question. I will park that question for a second now, but bear with us because the UTC will answer some of the presentation, will answer an aspect of that, but Steph will answer your question, okay?
Thanks.
Lovely. Any more comments to the EART at the moment? Okay, if we fire off the UTC presentation, and I apologize, you have to watch yours truly again, I'm afraid.
In this presentation, I want to give you a bit more insight into our UTC project. Now, this was based on our EART model, and we do believe that the national UTC program has been informed by our EART model. As you can imagine, working across 3 different sites across East Kent is quite difficult for a company like ours. So we had to start working in alliance with other partners. So with the UTC, we formed an alliance. So that alliance from ECHAFT, IC24, ACP, which is Ashford Clinical Providers, and Invicta Health, was in the best position then to secure the contract over the next 5 years with a possible 2-year extension. And as per national model, this obviously is a primary care-led service. So it is really important to understand that every patient coming to the UTC is a primary care patient until proven otherwise. And if they're so severely ill that they need to go to the A&E department, then obviously they will be triaged very quickly to go there. The only other way to go to the A&E department is then via the back entrance, via the ambulances. And that primary care lead obviously is very important in the understanding of all this, and is also underpinned by our IT structure. We will include also minor injury into the UTC patients. So it's now a combination between minor illness and minor injury. We will have a combination of walk-in patients, 111 patients, and there will also be an element of digital first working. This, of course, is supporting the whole healthcare sector in Thanet and East Kent, in all honesty. And we are proud to say that this model was based on our EART model. And so we had our GPs already working in 3 years in the A&E department, and our ACPs. Now, ACPs, the advanced clinical practitioners, are an important element of this work, because not only because they're very high efficient workers, but they also bring a different element to the clinical working, always led by our GPs. And we have been instrumental in making sure that our East Kent model includes ACPs for minor illnesses. We've also been instrumental in supporting the IT solutions, and yes, it's been a long and quite difficult journey with the IT, but we are now there, and we have made sure that EMIS is absolutely at the core of the IT solution. So that really enables our clinicians to look at your patient records and also makes the communication back to you practices very, very easy and straightforward. And you're already used to this from our EART model and the CART. So I hope this was a good overview into the now UTC, and of course I open the plenary now for all questions and queries and comments.
Right, welcome back. So I will give you a bit more time to think about any further questions, and I will gonna Steph the chance to answer Mark with the questions he's raised.
Okay, so I think one of the things that we want to make absolutely paramount is that patients don't get stuck in some 111 phone call vortex when they have to speak to lots and lots of different people over the phone. Because if you have to tell your story once, twice, 3 times, it will drive anyone mad, especially someone who's feeling perhaps delicate and emotional and unwell, because some of our patients at the moment are really struggling. So one of the things we want to make absolutely clear is that we are not going to use 111 to filter access to the UTC. We will still allow walk-in patients. So if you see a patient or a patient rings up who you think is very unwell, clearly it's going to be a referral to the specialty as it would normally be. But if you feel someone needs to come up to be seen in A&E, send them up, and if they're suitable for the UTC, then we will see them. If you feel that they do need to phone 111 for further treatment, obviously that's fine, but what we don't want is for patients to end up stuck having to speak to multiple people before they can see anyone. And some of you may have heard about the possibility, and I know, for example, at the Royal Free at the moment, that every single 111 is then re-triaged digitally on the phone or by video. And interestingly, some of their statistics at the moment are that doesn't mean that they can close most of their calls. They're only probably closing 5 to 10% of those on the phone, and actually they're bringing the rest of them in. So if we do implement something like that, I absolutely want to reassure you that your patients will not feel that they're constantly being fobbed off and having to speak to lots of different people. And if they need to be seen, they will absolutely be seen, and that's for walk-in patients or patients who end up on 111, because we know the value of that, and we know that patients need to not feel like they're having to tell their story over and over again. Does that answer your question, Mark?
Yes, thanks. Yeah, that helps. I mean, the other thing that's just dawned on me, when you say if you've got a specialty you need to refer to, so many times in recent years, the specialty will say, send them to A&E and they can decide what needs to happen, which specialty they need to go to, gynae, surgical, you know. Yeah. So when they say that now, what would we say to the patient? Would they go to just pitch up at the UTC then, or?
I think that's when you might have to put your scary GP hat on and say, I'm not asking permission to send the patient up. I'm telling you that I'm sending the patient up, and for you to be seen as the specialist to whom I think, you know, they need referring to. And I know at the moment, and it is one of the things that has become even more apparent to me working in the hospital, that I'm sitting in one room and the surgical assessment unit is literally 20 feet away. Can I get a patient in there? I mean, I may as well be asking for a unicorn to come galloping past. So that referral pathway within, even when you're sitting there, is very difficult. And I think the trust are going to be getting some communication from me that actually perhaps has said that the teams need to understand that A&E is not a filter for specialties. If a GP who is experienced in the community feels they need a surgical opinion, then they go to the surgical assessment unit. That's how it should be. So we'll start fighting that fight again on your behalf. We know that we've been doing it, you know, for as long as you and I have been GPs, but I think it's probably even more important now that the EDs are getting more and more busy. So we'll fight it with you, Mark.
I would like to add a slightly more positive note on that. Yes, it is extremely challenging, and to some degree, the horrible CQC report that the aircraft has been suffering under, identifying that the multiple different pathways aircraft had implemented to give patients the opportunity to be infected at several steps through a journey in the hospital, has been recognized as a problem. So I think aircraft themselves are very keen to reduce that particular issue as much as possible. So there's already quite a lot of pressure to ensure that specialities will take on patients appropriately and quickly through the right channels and directly into the dedicated units. So there's that pressure, but we also have, obviously with our working with aircraft, we have good relationships with the people on the floor, and we address these issues in all sorts of different ways, at the top level and also at the floor level. So we, as Steph said, we'll fight that fight for you. It won't be easy, it won't be straightforward, but I think I'm quite optimistic that, you know, that we will get that sorted one day.
Good, thank you.
Sorry, Susie's got a hand up. Sorry, Susie.
Yeah, no, just on the same thing. I was thinking it can happen with, you know, orthopedic, surgical, gynae, urology, all sorts of specialties where it can be a real battle to get someone in. And actually, if you're going to have the end result be that you've got to send them to the UTC for another clinician to see, then you may as well just deal with it with a very brief phone call, because you're completely wasting your time getting them in, doing a thorough assessment, writing a nice letter. If that means nothing, because you can't then get them into the specialty that you're aiming for.
Yeah, we're definitely, and you know, we're not there to, you know what you're doing as much as we know what we're doing. It's not that you have to send to us to then send somewhere else. That's not right. You should be sending directly, absolutely. And I think what happens is that it's quite interesting. We have a rule that if a patient has been seen and assessed by a GP that day, then they don't come to the UTC generally, because we are not there to undermine our community colleagues. If you guys feel, you know, that's us as well. If you feel that they need an assessment, then they need an assessment, and we're not, as a GP, offering anything that you didn't. So that's currently some of the guidelines. If it's been a phone call and it's been brief, or actually we find out something else has happened, then of course we see them. We would never turn anyone away, but we're not there to act as another level of general practice or primary care within the hospital. If your expertise is exactly the same as ours.
It needs to filter down though to the admitting, you know, SHOs or SPRs in orthopedics, urology, gynae, surgery, because it can be quite a difficult battle when you're in the room with the patient and you, well, I think this is the best specialty. You have that conversation, then you start thinking, well, maybe I was wrong. You know, maybe they're right. Actually, they should go to this other better than I do. And it's
absolutely,
quite difficult to fight your corner.
So the UTC hasn't, as Steph said, clearly has not that function. What we can do, though, on your behalf, with our relationships in the management strata of aircraft and the operational teams we work with, is we can help aircraft to understand the plight and the difficulty, and make that work better. That's what we are doing anyway.
So are they allowing people to walk in the front door of the ED to go to the surgical assessment unit and to go into... Not
the front door of ED anymore. It's the front door.
How do they get there if they are referred in?
So they will say that the surgeons expect them, and they will be seen, and they will be directed to where they should go, i.e. the surgical assessment unit, medical assessment unit. So that should be really the norm in this situation. They should not even go to ED or definitely not the UTC, but it shouldn't go to the ED, because, again, that will create another potential contact, an infectious contact. So they should go directly to the units where they need to go.
So an example, someone who maybe you're querying a cord equiner and you really need them to get an urgent MRI and orthopedic assessment, they frequently try and bounce them and say no, ED, and then if they've got a problem they'll refer to us. So what do you do with those?
Well, again, I think you should put the pressure out and clearly say, this needs to be seen by the specialist. That's why I'm talking to you. I think they need to be flagged up. We're quite happy if you flag them up towards us as well, so we can make those points. And that's really also something in A&E department which they need to sort out. What should happen is that those patients go to the appropriate unit directly, ideally, in this case, actually the MRI department, have the MRI and then being seen directly. So that is difficult. Rakesh wants to come into this discussion as well.
Thanks, Marcus. Susie, just to say that if you've got a suspected cauda equina, I appreciate sometimes it's a non-malignant cause, but if it's a malignant cause you're suspecting, you have a completely straight, direct route to any acute oncology nurse at our QEQM site. All you need to do is find her, and they will take the details and do all the necessary coordination. In terms of cauda equina, when it is a non-malignant cause, if you ever have anyone questioning that, please, we can escalate that. That should not be happening. If you are suspecting it in the community, you speak to your acute physician if necessary, if no one else is listening, but please escalate them and we will find a way of sorting that out. That shouldn't be happening.
Sorry.
Yeah, I think part of our remit is try to help you with that and support those sort of processes. So Ash said could send them to him, but I think if you can send them to Ash to us, we take these things forward and we will get them to the right teams one way or the other.
Can I ask one more question?
Of course.
There are many, we will have all had this situation where you can't get through to the specialty in the first place, let alone argue your point. So those patients often, we have no time to wait the amount of time they take to answer. And many GPs will be sending patients up to A&E traditionally and saying, well, I've tried to refer to the specialty, and you write that in your notes, but I couldn't get through. So what will you do on the front door at UTC with those sorts of people?
At the front door, every patient walking into the front door will be triaged first. Okay, that happens with a GP support by a Band 7 nurse. If they identify an acute medical, surgical, orthopedic, whatever need, they will bypass the UTC and hopefully be seen then in the ED actually, and then refer to the specialty directly. So those pathways are still open. And that should hopefully also be fairly quick, because with the triaging we're doing in the UTC, that's one of the advantages of doing this particular UTC system. The triaging should happen really quickly. And the IT systems, which nearly there, not quite, should support also those processes.
Thanks.
Okay. Any more questions in regards of the UTC? Okay, brilliant. So this is the time where I have to bring Rakesh in, of course. He's been kind enough to offer his support in presenting about CR, because obviously he's the leading light of the CR team and the project in many ways. This now is not a pre-recorded video, so Rakesh, you will have to give the good old next slide or next point, please, to Jake, who will run the presentation for you.
Thank you very much, Marcus, and good evening, everyone. And I do apologize for not being there physically or pre-recording it. I haven't been very well, so please bear with me. So to start off with, I'd like to say that CART was founded in 2016 by a certain doctor called Ash Peshen, supported, of course, by many others at the CCG. And two particular individuals who are part for KCHFT team members, Sarah Wolf and Nikki Davis, who are our senior decision makers. We're based at Westbrook House. We work as a multidisciplinary team, and this is a partnership working from 8 o'clock in the morning till 6 in the evening. We did extend our hours in the pandemic, 8 to 8, and we hope to soon to do the same with Marcus and the Thanet Health help, who now host CART. I'm sure many of you have used CART over the years, and the vision when it was founded was to try and support the complex and frail patients, both before they have to go into hospital, when they are in hospital, and how we support them after they come out of the hospital. At present, we support all Thanet-wide practices, including ASH surgery within the QEX PCN. And our aims are really very much around frailty, holistic, complex care in the community, and to minimize inpatient hospital care where appropriate. We're also supporting Westbrook House upstairs, where we have Victoria unit, where we've got 50 embedded units to support step up and step down patients. Now, I'm sure you'll all agree, we know that patients in their last year of life, and particularly last 3 months of life, often have multiple hospital admissions. And we know from recent reports that top 5% of patients are almost costing 20 times more than any other patients within the NHS. It is not their fault, it's just the way things are. And CART, with the multidisciplinary team, working very closely with the ambulances, the care homes, the GPs, the hospice, all the acute hospital doctors, of course the home visiting team and EART have been supporting this cohort of patients. And I'm sure you're aware that, as Marcus said, we've seen since 2016 around 5,200 patients, and as he said, avoided at least just under 1,500 admissions. Our average length of stay in terms of our care is around 14 days, but often our patients are discharged from the ART team much more earlier where necessary. We use EMIS records, we record our case fees and notes actively. We obviously communicate with GPs wherever necessary and possible for more urgent matters. We're also trying very hard to connect to all the community MDMs that are going across the PCNs at the moment. And going forward, we want to work with the PCNs, work with the MDMs and the community teams that these PCNs have to provide a much more holistic frailty focus, as well as provide a comprehensive geriatric assessment, treatment escalation plan support. And we've been working very closely with our community geriatrician, Dr. Upasana Garbaran. As a GP of 30 years, I'm very aware that GPs and their teams, all nurses, all doctors, and everyone involved in primary care are very keen to support their own complex frail patients. But we also know across our locality, as Marcus mentioned, with COVID, other pressures, sometimes this is not always possible. And we are able to bridge that gap and respond much more quickly as a multidisciplinary team before they go in hospital. And if they do go into hospital, we follow them up and see what's happened, and when appropriate, support them on their way out as soon as possible. In recent times, the hospital have very much welcomed our input at their board rounds, so much so during the first wave, when we stopped going in due to infection worries, they were very much missing CART input and asked for us to go back again. Now, I'm sure you'll agree, we couldn't do any of this without an absolutely amazing team. We have about 8 to 10 GPs, we have regular day GPs, and we're very, very keen to work as a team, not only as GPs, but a whole multidisciplinary team. We have an MDM twice a day, and we're very keen to support our primary care colleagues and the whole communities across Thanet and beyond with complex and frail patients, and in particular, end-of-life care patients. Should you have any questions, I'll be delighted to answer them with the rest of our team. Thank you.
Thank you, Rakesh. And you nearly kept to the 3 minutes. Well done. Well done. So bless him. Rakesh has been clobbered to keep it, very brief, because he has got so much knowledge and stuff to share that he has a tendency to get carried away, and it's wonderful to listen to him. But we tried to keep this particular meeting fairly short in total. However, I would be, again, any questions in regards to CART, complex art, are very welcome indeed. So are there any particular questions or comments you would like to make or raise? Okay, so I can't see any hands. And so that concludes our operational reports. So I would like to say that from our point of view, I want to thank any clinician working with us, for us in primary care. I just want to say a big thank you. I know that we've been all working very, very hard to keep our patients safe, to do the best for our patients, to make sure that the services are running. And I think it can't be underestimated how much work we're putting into this every day, and go every day beyond our calling and do 150%. So I just want to say a big thank you to all of you guys. I also need to say thank you to two particular people, particular at this point, just because they've been instrumental in getting things going and trailblazing what we are now picking up. So Rakesh, we want to thank you particularly for being the trailblazer in CART, and this project has been recognized nationwide, and a lot of people are now trying to copy you and just not getting quite there yet. So no one can really copy you, Rakesh. But that's it's a wonderful thing to see that idea is gaining speed and it's been distributed nationwide. And I also have to thank Ash for his hard work and all the things he's been triggering off and opportunities he's been spotting. And we do all like to swear at him at times because we're picking up stuff. We sort of the hubbub he creates. But I have to say this is really good work, and it's wonderful to have him to be able to trigger off things, get things moving, get past the whole sluggishness of NHS sort of trying to do anything going. So we want to thank these two guys in those regards. So thank you very much.
Thank you, Marcus. It's very much a team effort, Marcus, but thank you very much.
I would just second that what Rakesh just said. No, nothing can be done by an individual. It's always a team. So this concludes the operational part of our AGM, and we're actually bang on time. I'm actually slightly early, which is not expected. I have to say, everyone is here in the room is looking slightly surprised. So we're coming to our financial report now, and I have the honour of introducing Graham. Sorry, I'm trying to point. I know where Graham sits, but I'm looking at the screen and it's the wrong direction to point at. So I will give Graham the word and the screen.
I've just asked Jake to put on a slide. Earlier on today, we put the accounts onto the website and sent a link out for everybody to view, but I thought I'd just give you a snapshot for now, just as soon as the slide appears on the screen.
Oh, just G8. We're getting there.
Yeah.
We're going to do a little dance.
Any second now. This is it. Yeah.
Hey, we got it.
Yeah, there we go. Yeah, just to point out a few areas on there. I mean, obviously turnover for the company 1.5 million with the cost of sales of I can't even read my own writing here. 933 is that? I can't even see it.
It's on the screen.
931. Can't read that. Obviously, giving us a gross profit of 662. I've a detail below what the turnover and the cost of sales are there, and obviously after tax we are looking at retained earnings of 441. So a very successful year, and I think that just goes to show with the contracts we've got and the services that we're providing, and long may it continue. If you have any questions, obviously feel free to ask them now, but I'll probably take them away and come up with an answer and get back to you. Or feel free to email me, and I'll get back to you as soon as I can.
Right. So I just want to say that every document we've shown here are available on the website link I shared earlier. And also we will make sure that you have access to the presentations. And there also will be a recording of this AGM overall for people to admire if they would want to watch it again. Yes. I hear some comments from behind me. I don't know what they're saying. Anyway.
Might be a good cure for insomnia, Marcus.
So if we go back to the meeting, are there any particular questions you would like to raise at this point?
Marcus, I'm just thinking it might be nice to talk about the future in terms of ED and the UTC having a nice new place.
Right, okay. So Steph just pointed out that it might be worth to point out that I've already put it on the chat because one of our workers, bless her, was saying that the current geography and places we're working in is not optimal. I think that's the best way of putting it. So we will, the ECAFT has secured quite a lot of funding, so the UTC will be the front of ECAFT for patients to walk in. It all will be shiny and beautiful and wonderful, and so you know that's obviously something that will happen also very soon. We expect this to be happening beginning of next year. The planning and how this is working is starting. I think today was the first meeting. But we will be also intimately involved in the planning of the UTC and the layout and everything else. So that's good news from that point as well. So if there are no further questions so far, I would go to our next part, which is all about the structure and governance of our company. And I just would like to sort of introduce that section with us having been now working quite hard, acquiring our CQC rating, being operationally, heavily involved in several services, building alliances. We have learned immense amount of different things in the last year. And so we start introducing the governance section with, again, another presentation. And again, the chat is open.
This presentation is about our governance and memberships. I will explain what a member and a stakeholder is, and I explain our governance overall. Now this comes from a lot of discussions we had, and Ash will remember the initial discussions very well. But having been a company and a provider for a while now, we come to a maturity where we think this model would work really well overall. So I will start with the partners. We have obviously different tiers, and we have the directors, the members, the stakeholders, and the wider environment. The directors basically is us three, so we have Graham, Sandra, and me, and obviously we are responsible for the overall running of the company. We have members, so we expect to have one formal member representing each of our practices. And that should make sure that our members really have a good stake in our company and can influence our direction. We then have the stakeholders. So this is open to all clinical and non-clinical primary care staff and obviously the staff of the Thanet Health CIC. And again, this will come with a number of really good benefits, but they will have not the same influence into the strategic direction of our company. And then obviously we have lots of partnership working. So we have, as we well know, the UTC already with the Partnership Alliance, the East Kent Alliance, and then we have all the different people we're working with across Thanet and East Kent and Medway to make sure that we have good delivery throughout all the different professions. This then is followed by the meetings or the governance describing this further and making this possible. So we have the CIC board, which is the directors, and we meet once a month. So we want to make really sure that all our services are running well. We have the final decisions in the direction of the company, and we will also make sure that we have the right people at the right levels. This is underpinned by the quality meetings. So this reports to the boards and is put together by our clinical and quality leads. And we want to make sure that we're auditing all our services really well and that we have excellent quality and patient experience. So this now represents our internal governance structure. But as you well know, we want you to be involved, and I want you to be feeling part of the company so you can really make a difference of what we do and how we do things. So we have a strategy group, and this will be attended by the clinical directors and the practices, us KIC directors, and we aim to meet every second month. So that will help the company to really ensure that we do what's important for the practices, do what's important for primary care within Thanet, and just touch base on a regular basis. Also, we will find out what's going on further, where are opportunities we should seek, where should we invest time and resources. And then we have the annual general meeting, which obviously is attended by all our stakeholders. We meet once a year. We are, like today, celebrating our successes and show our challenges. And also we want to make sure that everyone can hold us to account and give feedback. So I hope this gives a good overview of our governance and membership. We will explain membership and stakeholdership in more detail in the next presentation. All questions, as usual, are welcome.
As usual, all questions are welcome. I can only repeat myself here. You're remarkably quiet, you lot. If there's no question at this point, I will carry on and give you a bit more insight what we think members and stakeholders could be like. And again, any comment, any question, any challenge, is welcome. So you can talk a bit more. I want to encourage you now. So we fire off our next little presentation.
Now I will talk briefly about what it really means to be a member or a stakeholder and what really makes it tasty to be part of the Thanet Health CIC. So I will share with you this beautiful slide. So there are several elements to this. So in the green are our members and stakeholders, so where we do give our support as quickly as possible at pace, and we will only do those if there are costs occurring, we will do this at cost. For non-members, we will not be able to react that quickly, and they will have to bear with us for some weeks, and we will do proper business cases and make sure that we obviously have proper costings, and all the intellectual rights are ours, which will remain ours for any service that's offered. And there are obviously a few bits which will not apply to members because these are sort of representative practices, and stakeholders are individuals, so things will not apply in the same way. So let's go through that particular graph, and I'm moving the window out of the way, and you will now see this beautiful graph. So what you should see now is that obviously we have on the right the columns for the members, stakeholders and non-members, and on the left we have the different rows and blocks which will denote different sort of levels. So for our members and our practices, we obviously will support them not only with our commission services, but also with our workforce support and physical times and emergency support and desk and contract support. We will really want to expand our training support, substance training we will offer, and then access to our clinical resources, mainly through our website. And I will show that in a minute in another quick presentation. And then we offered our members also back office support. Now that's not individuals don't necessarily need back office support, so that's why that is not applicable. But for our members, we definitely will want to do that too. And then the engagement and communications obviously are important. Non-members will be not invited. And as you see, the non-members practices or will have all these things available to them, but as proper costed business cases and structures. So I hope this makes this a bit clearer what it means to be a member, what it means to be a stakeholder, and please ask away.
Righty-ho. So, what do you think, guys? I'm not entirely sure whether I made you fall asleep or whether you're just stunned by the amazing work we're doing, or just stunned in horror. So I think it would be good to have some indication what you think, guys.
I think there's some, it's Julie speaking, I think there's some very good ideas there as to what the kit could possibly help with. But what sort of concerns me slightly and always has done is your capacity to help with some of that. Certainly historically it would have been poor old Graham sitting there that probably would have been the one lumped with providing a lot of the things that you've got on the list there. So what structure do you have in the kit to realistically be able to offer some of the support you're talking for practices, knowing just how busy, you know, general practice is and management within general practice and things like CQC and stuff like that?
So I'm glad you asked that question, and thank you very much for that. So I will start answering that question, and I will then hand over to Sandra and Graham a little bit as well. But our team is growing, and we have managed to secure a really good team around us who developing those skills. And you're quite right, there are also gaps we still need to fill. But we are now in a position, our company has now grown in a way that we will be able to bring support very quickly to surgeries, whatever the need is. And then we also are in a position where we can also make investment into further steps and get this going fairly quickly. So that's what I would say in general. I mean, Graham, would you like to add to that?
Yeah, I mean, I think we've talked at practice manager meetings in the past about the different roles that the PCNs require and looking to sort of share resources amongst the practices. But I think that we are now in a position where potentially we could employ the staff and certainly for the members be able to allocate resources around, because surgeries might not necessarily need to employ someone for you know, a huge number of hours, and so to get somebody of good quality might be difficult to do. And whereas, you know, we may be able to find somebody that we can employ and also deploy in certain practices across the week, and also use them internally when the demand isn't there. So I think we're now in a different place to where we were 12 months ago.
Yeah, and can I just say, with regards to the what we're planning at the moment is a teaching arm to Thanet Health CIC. We've got a very different team to what you've seen in the past. Obviously, Rakesh has now joined us formally, and he's very well known for his teaching. We were having regular teaching sessions with Rakesh up until not that long ago, and we're planning on resurrecting that with Rakesh's permission. But we also plan to arrange a lot of learning opportunities, short teaching days, so prescribing updates and specific teaching sessions that we're going to be able to offer out to the PCNs generally and members of the UTC. It won't just be about the PCNs, it's going to be the UTC and we'll be offering those to our Alliance members as well. So with Steph sitting next to me, she's a qualified teacher, I'm a qualified teacher, Rakesh is a qualified teacher, Marcus has obviously been heavily involved in teaching. We have a very different team to what we had perhaps in the past. And between us, we're planning a number of different learning opportunities, and certainly the strategic days, the strategy days and meetings that we're going to be having with you guys, those needs, your learning needs, can be identified, and we can then include that within our plans to deliver these sessions. So some things will just be podcasts, some will be teaching sessions, so hour or 2 hour Zooms. There might be some practical sessions thrown in as COVID allows. But you know, we're just really asking you to watch this space. And now that the UTC is up and running, we're going to be able to start planning our teaching arm, shall we say? So I know that Susie and Rakesh want to talk. I would like to answer the question around the training hub and CEF. And yes, we are working on this, and we don't want to duplicate anything that's offered with the training hub or CEF. We want to make sure that we are working together with them and just complement those sort of services and provided, and we want to support that as well. So coming back to the original question, we are in a very different position than we have just a few months ago. So yes, so Rakesh was putting his hand up. Susie's having a hand up as well. Susie first, sorry, Susie was first.
Yeah, no, I was really pleased to see on the last bit of information you put up about the potential for helping the PCNs with applications, for contracts. You're probably aware that one of them, well, not everyone might be aware that I'm the deputy on the Medway CCG, representing Thanet, along with Ash being the primary elected GP in that role. And one of the roles I have is to sit on the Primary Care Commissioning Committee and the Primary Care Commissioning Operational Group for Thanet and South Kent Coast. And recently we've been made aware that there was quite a big underspend in the additional roles reimbursement scheme for East Kent, particularly for Thanet. I think there were no applications for using the underspend that had been made available for any PCNs to apply for across the whole of Kent and Medway. So several PCNs in other parts of Kent and Medway did apply and were successful in their bids. But it's not too late for us to apply for 2021 funding for these last 4 months of the year. So it'd be brilliant if Thanet KIC can get together with the Thanet CDs of the 3 PCNs to hash something together so that it fits within the eligible roles. But Bill Miller, he's the director of primary care for the CCG, is very much welcoming any applications from Thanet that would fit within the eligible roles to try and get that money utilised to actually get the service rolled out in these 4 months, and we can not lose that from the system. I think if it's not used by then, it will just go back to NHS England and not be used.
Or plug some CCG holes. Yes, absolutely. Thank you, Susie. That's very valuable, and we'll pick that up. And again, I just want to say about the strategy meetings. Now, the strategy meetings are notwithstanding. They're part of our company structure, but are also very much aware that our forum meetings we have Tuesdays have been very useful to touch base, and they will still continue either on a two-weekly, every bi-weekly basis or weekly according to need at the time. So that is notwithstanding. So the initial structure with meetings we've shown obviously is all to do with making sure the company is doing things and we minute them, and all the tours and structure will be part of that. But forum meeting and other meetings are still there to touch base, to work together. There's many more things we need to do. Yes, there's quite a lot of stuff happening on the chat as well. But Rakesh want to say something.
Thank you very much, Marcus and Sandra. I just wanted to kind of echo what Sandra said, that education is a great enabler, particularly pragmatic education. And we very much want to work in partnership with everyone. Of course, training helps the CEF, as you say, Marcus. But also, I know, Mark was just pointing, or somebody was pointing around Invicta as well. So we will work with everyone. We want to work as communities of practice when it comes to education. Also, as a Kent and Medway CCG education stroke quality and learning lead, I think it's really important that we share our learning. Particularly, a lot of our complex patients are looked after by so many professionals across boundaries and so on. And we know people are very busy. So what we're going to try and do, as you say, Marcus, is we're going to concentrate our minds to see how we have high impact education, which can be accessed very, very quickly at appropriate times across our localities.
Thank you, Rakesh. That's a very good point well made. So, great. So that's, at the moment, concludes this particular section, and the next bit would be talking a bit more about the resources and exploring this a bit more, what we started to sort of develop within the KIC. So I think it's time to fire off the last presentation. I can't believe we already made it. Within just about an hour, we made it to the last presentation. So we're doing very, very well, actually. So let's go for that, and we'll see each other on the other side.
This time I would like to give you a really quick overview of our resources. So we talked about stakeholders and members, and we are already working with such a wide variety of professionals that we really feel the training is a part of what we want to develop further in the Thanet Health KIC. We're also blessed with the fact that we have contact and access to high quality experts in training and education, and we want to make full use of those. So that will help you guys as stakeholders and members to have access to high quality training, but also this training will be available to everyone who works with us. I also want to give you a quick overview of our website just to show you what's there. If you go onto the professional button here, that will give you access to more resources behind the website, and obviously you would be stopped by the login screen first. I have logged already in, so it makes it quicker. If you want to take part in our mandatory training function, then you would have all your training displayed to you, which is mandatory to you, with the completion dates and renewal dates, and would get automatic updates. We have obviously our protocols and news available as well, but you know, this will obviously change as the need changes. We have then our tabs up here. So in references, we have the immediate available resources for our clinicians, the not quite so immediate necessary resources for our clinicians with handbooks and protocols and policies. The personal development brings you to the mandatory training page, so you can upload certificates and things like that. The clinical references currently are about the ECHAFT formulary. You will be able to see our primary care prescribing guide, and we have, for people who work with us, we have also access to NB Medical. So these are the references. We're also going to work on a referral guide. So this should be then a resource for all our members and stakeholders to look quickly up. Oh, if I want to refer to this or that service, here's the referral form, here are the criteria, and here this is the best way to do this. So we work currently on with admin staff from primary care surgeries to get this going, but we're not quite there yet. We are quite proud of our service map, and I would like really to show that briefly to you as well. So you see all the available services within our map, and you can select any of these different filters on the right. You see the dentists, and you know which ones are the NHS dentists. You see the GP surgeries, and if you click off any of those icons, you will get more information. So if you go into the hospital, I quickly want to show you that as well. If you go into the hospital and you click on this, you obviously get the basic information available to the public, but because you're logged in, you will have access to the referral info. So you will see much more behind this, and you will have access to clinically relevant information more than you would do if you just go on the public side. We have the opticians, with the MECs that are denoted by the red cross. We have the pharmacies. The pharmacies logos show the weekday closing times, so it should be really quite useful for you in your daily work. And then physical therapies, And then we have the help organizations. So this is basically the third sector and should be a good resource, not only for the GPs, but also our focused care teams and social prescribers. And if you then have also services which are available to us, but not necessarily based in Thanet, if you scroll down, you will find the information on how to contact them and their websites and everything further in there. So I hope this gives you a quick overview of our website. We obviously have a news page and we have our minutes and reports published also on this. So I hope this is helpful to you. I don't want to make this any longer than it already has been. So again, any further questions are welcome. And I want this website to be really, really useful. So no clinician or anyone working with or for us will want to close this web page. So any further suggestions of what would be useful are very welcome indeed.
Right, I'm still typing answers in the chat. So, yes, any particular questions to this bit? Ash has his hand up.
Marcus, actually, this is very good in terms of, because I remember at one time when Dr. Seamus Henry was here, he had done something like this, where to refer kind of a thing in Thanet. That was actually a good kind of thing which they did. I know some other part of the, like in South Kent Coast and in Ashford in Canterbury, they try to do something like this. To be as I just responded to Nikki, it was an unmitigated disaster. It didn't go anywhere. It hasn't really gone anywhere. Now, the other thing which I wanted to ask was, I didn't see many local services in this. Is there any options as we go forward to be able to add in terms of what if I've got a patient sitting in front of me in terms of children's services and other services? For example, if I need to get some social help for the patient, like for example,
I think. Thank you for that. I'm surprised to say there were not very many services on this. I'm furiously typing now to get into the web page because this is a quite a highly developed sort of website, and there are plenty of other services available.
As Billy mentioned in the message, it's I was more looking at voluntary care sector in terms of. If I want to go into some voluntary care sectors areas, which ones can I tap into? Okay, so there are plenty on the right menu. Obviously, I tried to keep this presentation as short as possible, but there are nearly all third sector services are represented, which are available locally on this webpage. I mean, I can try it and share. I'm not quite sure whether I'm actually allowed to, but. I can't share from this particular computer, but on our website there are plenty of third sector organizations mentioned, and if they're not located in Thanet, if you scroll further down, as I said in the presentation, you find actually more information available there as well. Once you get to the login pages, and that's obviously something we need to organize. So everyone who would like to have a login to this page, as a member, you would have that anyway. But I think we need to have a list of people who would like to have logins to this page. So you get also the clinicians or NHS background information available to you, so you can get quicker into those services or have referral forms or additional referral info, which should not be available to the public. So there are many more things we can do. Having said all this, I would like to point out that we are keeping this website also up to date. So we have someone working on this who keeps this site up to date and checks it regularly. Very important point. And furthermore, if you find anything that's missing, that's a weird thing to say, but if you feel there's anything missing, please let us know, because we need to rely on other people to point out things to us if there's a new service developing and we for some reason haven't heard. other thing which I need to ask Marcus is thank you for answering that. We can, as members, register with that. Now, the question I have is as a member, is it just the clinicians who are members? But because I've got a lot of staff in my practice who are non-clinicians, like the admins and others, who would benefit from having access to something like this. So, would they be able to be able to tap into this resource?
So first of all, I would say that this particular benefit of having access to the website and the referral info would be part of the members and stakeholders benefit. Okay, so that also means that as a member practice, or having a member representing the practice, that means that all people who would benefit from the information available on the website will get also access to it. So we need to have the information from the practices whom you would like to be included, and we obviously will make sure that they have access. The chat is sort of slightly veering off the professional and going to slimming world, and which is right. We should obviously also help for obese patients and those sort of groups. The difficulty with businesses, to promote businesses where people need to pay, we get actually into a bit more difficult waters. So we cannot necessarily recommend professional commercial business like this. And particularly if you then start about takeaways, I think there are other resources on our website to go to, I would say.
Google.
So, well, I'm flabbergasted. My flabber has been gasted that we are now at the sort of nearing the end of the AGM, we are now at the point you have a good overview of our company, you have a good overview of our current run services, you have a good overview of our governance structure and membership and stakeholdership and all these sort of beautiful things. So some of you will also be aware that we are still working very hard in the background to securing support and funding for our primary care delivery in terms of COVID response and hot site and all the other particular bits around that. Jenny and Andrew and Ghana and Ash, we've had already furiously doing things in the background today about those sort of matters. But it also gives you a chance where you see our future as a company and working for you, where we should go and what we should do. So please fire ideas, comments, concerns, challenges at us right now. Ash hand, is that a historic hand or is that your hand still up, Ash? The hand went. So, right guys, have we put you successfully to sleep? Right, now I see some smiling faces, which is lovely to see. Rakesh, your hand is up.
Marcus, I know you said I speak too much, but I have to, I'm afraid. And I just wanted to say thank you very much to you, to Sandra, to Graham, to Ollie and anyone else I've missed. And of course, Stephanie and me as clinicians, we say thank you to each other in other ways. But I know you do a lot of work. And I just wanted to say a massive thank you. We really appreciate what you do and the team does.
Or even unmute myself. Thank you, Rakesh. That's very appreciated. It's lovely to hear that we make a difference. And I also, Julie Hill has an idea of whether the website could develop a place for social element for local staff. So I think that's something definitely we could take on. and develop further. So we will take that back. I will also say that we publicized our AGM for stakeholders and members, not for the public, on the website, so you will have access to that. Again, we're recording this AGM, so you can also watch it back. The good thing is you can slide over the boring bits and go to the bit you're actually interested in then as well. All the presentations, all the videos will be separately available for you to watch again if you feel the need to do so, brave people. And we are open for any suggestions, not only now, but if you have any comments, any questions, any things you feel we could support, help you with, come to us and we will do anything we can. And if we can't, we point you to someone who does. So, you know, I want to thank you all again, because without any of you, nothing of this would be possible. So I'm feeling pretty warm and fuzzy right now, which I hear some giggles and comments from the back here. So if no further comments, we would be able to actually finish the meeting ahead of time. Well, there are no comments. Everyone is hungry and wants to go and do their things. So thank you again, everyone, and we'll see each other soon. And keep up the good work. Bye bye.
Thank you.
Thank you.
Thank you.
Bye.